Video on pneumonia. Pneumonia refers to an infection of the lower respiratory tract and the lung parenchyma. It is evident on a chest X-ray or a CT scan as consolidation. Radiological evidence of consolidation is necessary for a lower respiratory tract infection to be labeled as pneumonia. Pneumonia can be of the following types: community-acquired pneumonia, hospital-acquired pneumonia when the infection is acquired during a hospital stay, aspiration pneumonia, and pneumonia in the immunocompromised adult. The common organisms causing community-acquired pneumonia are Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus, and bacteria causing atypical pneumonia, namely Mycoplasma, Legionella, and Chlamydia. Hospital-acquired pneumonia is usually caused by resistant gram-negative bacteria like Klebsiella and Pseudomonas, or Staphylococcus aureus, including MRSA. Anaerobes are often responsible for aspiration pneumonia. Patients who are immunocompromised are prone to infections from opportunistic organisms like Pneumocystis carni, fungi, viruses, and mycobacteria. Viruses can cause pneumonia in immunocompetent hosts also. Viral pneumonia is more common in children but may also occur in adults. COVID-19 is an example of viral pneumonia. The patient usually presents with a history of fever for a few days. This may be associated with chills and rigors. The patient also complains of weakness, lethargy, and poor appetite. Cough is usually present. To start with, it is often a dry cough but progresses to productive cough. Hemoptysis may occasionally be associated with the cough. Sometimes, if the infection involves the outer surface of the lung, the patient may experience pleuritic chest pain, which is sharp and worse on inspiration. On examination, the patient may be febrile. Depending on the severity and the level of hypoxia, cyanosis may be evident. The respiratory rate and the heart rate may be elevated. Blood pressure may be low, especially if the patient is in septic shock. Some patients may be confused. On examination of the respiratory system, expansion of the chest wall on the affected side may be reduced. There may be dullness to percussion over the affected area. Vocal fremitus and vocal resonance are usually increased, and bronchial breathing and or crepitations may be heard on auscultation over the affected area. If the infection and the resultant inflammation involves the pleural surface, a pleural rub may be appreciated on auscultation. These are the investigations that are usually done in patients suspected to have pneumonia. Full blood count usually reveals a neutrophilic leukocytosis. Urea may be elevated and is one of the markers of severity of infection. Hypernatremia may be seen and is more common in atypical pneumonias. CRP is usually elevated in bacterial pneumonia, and a reduction in CRP is seen with response to treatment. Blood culture should be done in all patients who are admitted to the hospital. If the cough is productive, A sample of the sputum should also be sent for culture and sensitivity. Chest X-ray reveals consolidation and establishes the diagnosis. Occasionally, a CT scan may pick up a consolidation that is not evident on the chest X-ray. This is an example of a chest X-ray showing consolidation in the right middle and upper zones. This is seen as a patchy or non-homogeneous area of opacity. This is another example of a chest X-ray showing consolidation on the right side, here mainly in the lower zone. An air bronchogram, if present, is pathognomic of consolidation. Assessment of severity is an important part of the management. Curb 65 scoring system is used for severity assessment in community-acquired pneumonia. Here C stands for confusion, U for urea above 7 millimoles per liter or 40 milligrams per deciliter, R for a respiratory rate above 30, and B for blood pressure, meaning a systolic blood pressure of less than 90 millimeters mercury and a diastolic blood pressure of less than 60 millimeters of mercury. 65 refers to the age of the patient being 65 or above. Each variable carries 1 point. The minimum score is 0 and the maximum score is 5. Patient with a score of 0 to 1 can usually be managed with oral antibiotics on an outpatient basis. If the score is 2 or above, the patient should be admitted to the hospital, and a score of 4 or 5 warrants admission to the intensive care unit. Oxygen should be given to maintain an oxygen saturation of above 94%. In patients with pre-existing COPD, a target saturation of 88 to 92% may be acceptable. Intravenous fluids should be given if the patient is clinically dehydrated or hypotensive, or if the urea is raised. Antibiotics are the mainstay of treatment. If the curb score is 0 or 1, oral antibiotics, for example, amoxicillin 500 to 1000 milligram 3 times a day, is appropriate. If the patient is allergic to penicillin, macrolides may be given instead. If the patient is suspected to have atypical pneumonia, then in addition to a penicillin like amoxicillin, a macrolide should also be given, for example, clarithromycin 500 milligrams twice daily. If the score is 2, then the patient is usually given 2 antibiotics, for example, a combination of amoxicillin and clarithromycin. Oral route may be sufficient, but the clinician may choose to give the antibiotics intravenously depending on the patient's overall condition and their own clinical judgment. If the curb 65 score is 3 or above, intravenous antibiotics should be given, and usually 2 antibiotics should be given. For example, the choice may be coamoxiclav or augmentin 1.2 grams 3 times a day combined with clarithromycin 500 milligrams twice daily. The duration of treatment is usually at least 5 to 7 days. Other alternatives are a third generation cephalosporin like ceftriaxone or cefuroxime, and respiratory fluoroquinolones like levofloxacin. If macrolides and fluoroquinolones cannot be given, doxycycline may be a useful adjunct to penicillin. Once the culture reports are available, the antibiotics should be reviewed and may need to be modified depending on the sensitivity pattern and the patient's response to treatment. Paracetamol is used both as an antipyretic agent as well as for its analgesic effect. These are some of the complications of pneumonia. Respiratory failure refers to hypoxia with a PaO2 of less than 8 kilopascals or 60 millimeters of mercury. If this is not corrected by supplemental oxygen alone, the patient may require ventilatory support, for example, with non-invasive ventilation like CPAP, and in some cases, even with intubation and mechanical ventilation. The infection may sometimes progress to a state of septic shock. This should be managed with aggressive intravenous fluid resuscitation, and if the patient's blood pressure does not respond to fluid resuscitation alone, they may require inotropic support, for example, an infusion of noradrenaline. Pleural effusion is a common complication. Occasionally, the pleural fluid may get infected and form pus in the pleural cavity. This is known as empyema and requires drainage with a chest drain tube. Lung abscess may form in the lung parenchyma itself. Sometimes the infection may embolize to distant organs, leading to abscesses in ectopic locations like a brain abscess. The metabolic complications of pneumonia include hyponatremia and renal failure, which are both more common in atypical pneumonia. Derangement of liver enzymes may be seen, and cholestatic jaundice may also be seen either due to sepsis or because of the side effect of some of the antibiotics that are used, like augmentin. Venous thromboembolism, meaning deep venous thrombosis or pulmonary embolism, is a complication of hospitalization and immobilization. So, all patients with pneumonia who need hospitalization should be given thromboprophylaxis, usually in the form of low molecular weight heparin, for example, enoxaparin 40 milligrams subcutaneous once a day. This should be given to all patients unless there is a contraindication. Thank you.